This video will cover agents used in the prevention or prophylaxis of migraine headache. I've shown this graphic to you previously. As a reminder, the drug classes or agents available for preventative or prophylactic migraine treatment are the beta blockers, anti-epileptics, antidepressants, Cgrp antagonists, and a few miscellaneous therapeutics. In this video, I will spend most time talking about Cgrp antagonists, as this is a newly presented drug class. The beta blockers and anti-epileptic drugs have been covered previously, and the antidepressant drugs will be covered in greater detail in IP8. As a reminder, preventative migraine therapies are given on a consistent or chronic basis, even during periods of time when migraine headaches are not experienced. The time in between migraine headaches is called the interictal period, and preventative migraine therapeutics are given both during the interictal period as well as during the ictal period when migraine headaches are occurring. Note that even in individuals who are taking preventative therapeutics for migraine headache, an acute or abortive therapy may be used in addition or added on when an active migraine is occurring. This table will be used as a brief review to some of the preventative migraine treatments that you have covered previously, and also to briefly introduce the use of a couple of antidepressant drugs for the preventative treatment of migraine. I will start by discussing the beta blockers. The three beta blockers that have established efficacy in the prevention of migraine headache are metoprolol, propranolol, and timolol. As you know, these agents inhibit beta adrenergic receptors. They do so non-selectively, with the exception of metoprolol, which is a beta-1 selective adrenergic antagonist. Take a moment to review your Integrated Pharmacotherapy 1 notes, where you would have covered beta blockers. As a side note, the beta blockers atenolol and nadolol also have some probable efficacy in the prevention of migraine, but the three beta blockers I listed initially are the ones with the established efficacy and best evidence for their use in migraine treatment. Next, I will talk about the two anti-epileptic drugs that are used in the treatment of migraine, and these include Topiramate and Valproic acid, which comes as either divalproex or valproate. Again, by way of review, Topiramate is a sodium channel blocker that decreases neuronal firing. On the other hand, valproic acid is an anti-epileptic drug that increases GABA signaling. One of the two things that distinguishes these agents is the fact that topiramate is associated with weight loss, which is sometimes of interest or beneficial when treating migraine prophylactically, whereas valproic acid is associated with weight gain. Again, take a moment to review your notes about these drug agents. The anti-epileptics were covered earlier in this course during the epilepsy unit. Next, I will describe two antidepressant drugs that may be used for the prophylactic treatment of migraine headache, and these are Amitriptyline and Venlafaxine. However, note that as indicated in this table, these agents have probable efficacy or level B evidence as compared with the level A evidence or established efficacy for the anti-epileptics and the beta blockers. The two antidepressants used in the prophylactic treatment of migraine have similar mechanisms of action, even though they are members of different antidepressant drug classes. Amitriptyline is a tricyclic antidepressant, or TCA, that inhibits the reuptake of serotonin and norepinephrine. One important note is that it is used at lower doses for migraine prophylaxis than it would be used for antidepressant therapy. Venlafaxine is a selective serotonin and norepinephrine reuptake inhibitor and also blocks the uptake of serotonin and norepinephrine. In general, the mechanism of action of these drug classes in the preventative treatment of migraine are as follows. For the beta blockers, chronic blockade of the beta adrenergic receptor results in a decreased ability for vasodilation to occur, which decreases the possibility of vasodilation happening during a migraine. For the anti-epileptics, these drugs generally decrease neuronal activity and therefore decrease the overactivity that underlies the pathophysiology of migraine. For the antidepressant drugs, these agents modify serotonergic neurotransmission and therefore have implications for the role of serotonin in the generation of an active migraine. The next class of drugs for migraine prophylaxis are the CGRP inhibitors or CGRP antagonists. These are drugs that both block the receptor-mediated activity of CGRP, as well as, in some cases, sequestering the CGRP molecule itself. As a reminder, CGRP stands for calcitonin gene-related peptide. This is a neuropeptide that is released during an active migraine and contributes to the vasodilation and release of inflammatory mediators that cause migraine pain and many of the other symptoms. CGRP is released in large quantities in the trigeminal ganglia, as well as in the trigeminal nerve endings, both in the face and in the head. The mechanism of action of the CGRP inhibitors is to block the activity of CGRP in several regions, including the trigeminal ganglia and the trigeminal nerve endings. This blockade of CGRP activity results in decreased vasodilation and decreased release of inflammatory mediators in the dural space. There are several CGRP inhibitor drugs that are FDA approved for the prophylaxis of migraine headache. These include arenumab, eptinezumab, fremanezumab, galcanezumab, and rimegepant. All of the drugs that end in mab are monoclonal antibodies. I will talk momentarily in greater detail about the features of these antibodies. The lone small molecule drug, rimegepant, is also available for the prophylactic treatment of migraine headache. Not surprisingly, the monoclonal antibody drugs, which are biologic products, are available in formulations for subcutaneous or IV injection. Most CGRP inhibitors are given by subcutaneous injection, with the exception of eptinezumab, which is given via IV. The small molecule drug, rimegepant, is available as an oral disintegrating tablet. All monoclonal antibody CGRP inhibitors have similar side effects, which include injection site reactions, the development of anti-drug antibodies, which can reduce their efficacy, as well as the development of constipation. The monoclonal antibodies as biologic products are not known to have significant drug-drug interactions. Rimegepant does not have significant side effects, but is a concern in individuals with hepatic or renal dysfunction, or in individuals who are currently taking strong CYP3A4 inhibitors, as this can decrease metabolism of rimegepant. As I mentioned previously, all of the CGRP inhibitors that end with the suffix mab are human monoclonal antibodies. There is a slight difference in monoclonal antibody type, depending on whether the suffix is zumab, which includes a Z, or umab, which has no Z. The zumabs, eptinezumab, galcanezumab, and fremanezumab, are what are called humanized monoclonal antibodies. These are drugs where the sequence is greater than 90% human. The best way to remember the humanized antibodies are that these contain a Z, because humanized and zumab both contain the letter Z. On the other hand, arenumab is a fully human or a 100% human monoclonal antibody. These can be denoted by the suffix UMAB, which contains no letter Z. And the easiest way to remember this is that this begins with a U, which is for fully human. The source of these monoclonal antibodies is different depending on which particular product you are discussing. Most are murine, which means they come from mouse. That includes galcanezumab, fremanezumab, and erinumab. Emtanizumab actually is developed in yeast. The IgG class differs slightly between these different antibodies, but that is not the most important feature. The most important feature related to the mechanism of action is whether or not these antibodies inhibit the CGRP peptide itself or whether they primarily inhibit the CGRP receptor. Erinumab is the lone antibody that targets the CGRP receptor and blocks the receptor from interacting with its ligand CGRP. On the other hand, the other CGRP monoclonal antibodies actually bind to CGRP itself and sequester it, removing it from circulation and preventing it from having any receptor-mediated activity. There are a few miscellaneous drugs for migraine that I also want to mention. For chronic migraine, which is defined as greater than or equal to 15 headache days per month, or in other words, having at least half of the days per month with a migraine. Botox or botulinum toxin injections are indicated for this purpose. But again, this is only for chronic migraine when migraines are disabling more than half of the month. Botulinum toxin blocks neuronal activity of cholinergic neurons. And therefore, the mechanism of Botox to reduce migraine is basically to paralyze or reduce activity in the facial parasympathetic nerves, which leads to the generation of migraines. The goal is that by undergoing Botox injections, those nerves become less active and decrease function enough to prevent the development of a migraine. Also, for menstrual-associated migraine, there are some specific therapeutics that are effective in their treatment. Menstrual-associated migraine can occur with or without aura, just like regular migraines. In the case of menstrual-associated migraine without aura, it is actually beneficial to use an oral contraceptive that is monophasic, meaning there is a single concentration of estrogen that continues throughout the menstrual cycle. This monophasic estrogen actually prevents against the development of menstrual-associated migraines because it is the change in estrogen levels that can potentially trigger a migraine. In addition, it may be beneficial for individuals with menstrual-associated migraine to begin taking a triptan and/or an NSAID prior to the start of menses and then for the next 5 to 7 days during the menstrual cycle. For menstrual-associated migraine with aura, it is important that individuals would use a progestin-only contraceptive, and that's because estrogen can increase the risk of stroke in individuals who experience aura. And therefore, a progestin-only contraceptive, which again maintains a consistent level of hormones across the period of the menstrual cycle. And in addition, those individuals could also begin the use of a triptan immediately prior to menses and continue for the 5 to 7 days of menses. Lastly, I will mention the agents that are used in the treatment of tension type and cluster headache. Most of these agents have been covered previously, and therefore the purpose of these slides is simply to mention what the agents are, and additional detail would be provided in the therapeutics section. For tension type headache, the therapy differs depending on whether there is acute treatment of an active tension headache versus prophylactic treatment. Acute treatment of an active tension type headache includes the use of either NSAIDs, discussed previously, or analgesics to reduce the pain associated with a tension type headache. The analgesics that are recommended include the butalbital containing products that were discussed earlier. For prophylaxis, the tricyclic antidepressant amitriptyline is indicated for prevention of reoccurring tension headaches. Again, amitriptyline is a tricyclic antidepressant that reduces both serotonin and norepinephrine reuptake. For cluster headache, there is indication for specific agents during an attack and a separate set of agents that can be used to prevent future cluster headache attacks. During a cluster headache, the recommended treatment is the use of oxygen, the use of a triptan, such as sumatriptan, and in addition, the administration of ergotamine. To prevent subsequent bouts or attacks of cluster headache, the prophylactic therapies include the calcium channel blocker verapamil, the mood stabilizer lithium, the anticonvulsant topiramate, and corticosteroids via injection. Again, the purpose of mentioning this is to list the therapeutics that are available for the different aspects of tension and cluster type headache treatment, and their therapeutic use and administration will be discussed later. At this point, now is a good time to review the role of the CGRP inhibitor drugs in migraine therapy. To do this, I've created a practice assignment in Canvas that will ask specific questions about the role of CGRP inhibitors in migraine treatment. You can take a photo of the QR code on the screen to directly connect to the practice assignment. As usual, if you submit the practice assignment by the stated due date and time, I will provide you feedback in advance of the exam on this content.